1,000 confirmed cases of Ebola.
Tonight, how the Ebola virus took the world by surprise.
This entire epidemic shows how difficult it is for the world to prepare for something that it's never encountered before.
And can we prevent its spread in Britain?
Britain, inevitably, over the coming months, if the epidemic continues in West Africa, there will be patients identified with Ebola in major cities of Western Europe, North America and elsewhere.
Good evening and welcome to the Tonight programme. On Tuesday, the government started screening people arriving at some major airports for symptoms of Ebola, the deadly disease that's killing thousands in West Africa. With experts warning we will see some cases here before Christmas, ITV science correspondent Alec Jar looks at how ready we are in case of a major outbreak. In Ebola, are we prepared?
With cases of Ebola appearing in Spain and the United States, the disease is now a reality far from where it started. The government here in Britain is on high alert.
It will not be surprising if we have spillover into this country, so I would expect a handful of cases over the next few months.
In December last year, a 2-year-old boy was the first victim in the world's largest ever Ebola outbreak. Just 10 months later, there are now nearing 9,000 confirmed cases of Ebola in West Africa. Around 4,500 are already dead, say official statistics. Experts warn the real figure could be twice that.
We know that the virus is raging through West Africa, particularly in Sierra Leone, Liberia, but also Guinea. We're seeing unprecedented amounts of infection compared to previous outbreaks.
The epidemic is out of control. That's not to say it's not controllable, and I think it is controllable, but as of today, yes, the epidemic is out of control.
We either stop Ebola now, or we face an entirely unprecedented situation for which we do not have a plan.
Until now, the threat of Ebola for people in Britain has seemed quite remote, something happening to people far away. But over the last week, we've all woken up to the danger it poses. For West Africans living here, the human cost of Ebola has been immense. In this Liberian community in Sheffield, nearly everyone has a friend or relative who's been affected.
There will be raised awareness of Ebola because there are lots of people who don't know what Ebola is.
Hi, Martina.
Hi.
Welcome.
Thank you.
Martina Cromer's family in Liberia has been ravaged by Ebola.
When people are dying, just one person brought it at home, but unfortunately for the whole family, we lost about 20 in the same house. Kids, adult, man, they started following each other one at a time.
A close relative was a nurse who unwittingly brought the virus into the family home. Over 3,000 miles away, Martina had to stand by, helpless, as one after another they fell.
They are calling me to do something, help them, and have no means. I can't even to help them. All I can do is just to sit and cry.
As this disease overwhelms the fragile health systems of Liberia, Guinea and Sierra Leone, the international response is gathering pace. But we've acted too slowly, and the experts say this outbreak should never have got so big.
The previous outbreaks, over 20, have all been stopped in rural areas by a robust and rapid initial response. Well, this outbreak is quite dangerous because it's the first time that the Ebola virus has gotten into an urban area where there are international airports.
Our neighbour's house is now on fire. How long before it comes to us? Researchers at the University of Liverpool have been modelling airline travel data to find out.
Since the start of the outbreak, we've been looking at the risks of it spreading, particularly by airline travel. And we've shown that the chance of Ebola coming to the UK has increased throughout the whole outbreak. And indeed, we're now reaching a point where, sadly, it does look inevitable that we will have a case coming.
As Ebola draws closer to our shores, are we ready? With tragedy unfolding in West Africa and cases appearing in other parts of the world, it's understandable that people here might be feeling anxious. But this is a disease that we can treat and contain given proper procedures, and we're learning more about it all the time. Now more than ever, we need to listen to scientists and healthcare workers who are tackling this outbreak. That's how we cut through the misinformation, learn how to keep ourselves safe, and most importantly, direct help to those who are suffering the most. Ebola, an often fatal virus, causes fever and severe internal bleeding.
The Ebola virus is highly infectious. We don't need very many virus particles to set up an infection. Thankfully, the virus isn't very contagious, so it doesn't spread via the respiratory route. It's nothing like measles or influenza. You need direct contact with somebody who's infected with their body fluids, so things like vomit, diarrhea, blood.
Professor David Heyman is an epidemiologist who's been fighting outbreaks of Ebola since its discovery in 1976.
If I were sitting in a room with someone with Ebola, I could be sitting a meter away from that person and I wouldn't be infected unless that person turned around and vomited on me or somehow infected me with their body secretions. So that's the good news. The bad news is, though, that it is a virus which is unstable in many ways, so it could be mutating in such a way that it becomes more virulent or less virulent, but it won't mutate in such a way that it becomes airborne. Some scientists have said this is quite irresponsible. Look at the viruses that we have that transmit in a similar way, HIV, hepatitis B. All those are blood-borne viruses. They don't change in the way they transmit, and Ebola will not change either unless it can develop a whole new viral structure, which would be very difficult to do.
In West Africa, there's been widespread transmission. We know that since the start of the outbreak, several countries have brought home citizens who've been working in the affected areas. 2 Spanish priests were the first to die in Europe. Nurse Teresa Romero was diagnosed with Ebola after caring for one of them. Hers became the first known case of transmission outside of Africa. Following the late Thomas Duncan's diagnosis in the United States, nurses Nina Pham and Amber Vinson have both tested positive for the virus after being involved in his treatment.
The recent events in Dallas and Spain have been very sobering. These are 2 countries who thought that they had become prepared. This entire epidemic shows how difficult it is for the world to prepare for something that it's never encountered before.
The government has assured us that here in the UK, we've got the best facilities, the best health service, and are prepared for any outbreak.
In the UK, we have dealt with hemorrhagic fevers before when they've come in returning travellers, even if we've not had to deal with Ebola before. And what we've shown in the past is that we're very quick at diagnosing these conditions, and we're very quick at isolating the patient and looking after them so that there's no spread to anyone else.
So there's a great system of detection of patients who might have Ebola. Then there's an excellent system of rapid diagnosis, and there's a superb system of isolation of patients. As we saw, there's already been a nurse who came back infected, very effectively isolated with no health workers getting infected.
British nurse William Pooley was flown back to the UK with Ebola in August. His treatment was successful, and the virus was contained with no further transmission.
We're taking all the steps we can to keep our own people safe here in the UK, and that's why we're introducing these screening processes at the appropriate ports and airports.
The UK and US governments have started temperature and symptom screening travellers from West Africa at airports, trying to identify anyone with a high fever, the first indication that someone might be sick with Ebola. Experts tell us that the most likely path of the virus into the UK is through air travel. Someone carrying the virus but without any symptoms might pass right through airport checks. Ebola has a long incubation period, so it could be anywhere between 2 and 21 days before a sufferer exhibits symptoms. So how effective is this airport screening going to be? I asked aviation specialist Dr. Lucy Budd.
Studies have shown us that airport screening in the form of taking passengers' temperatures or having some form of health questionnaire only have limited effectiveness. The thermal imaging cameras and the non-contact thermometers can return false positives, so people who have influenza, for example, can be flagged up as having a temperature, and the health questionnaires rely on people being honest about where they've been and where they're intending to go. So the actual screening measures that are being put in place ultimately perhaps won't be effective by themselves.
If you were speaking to someone who was a bit anxious about travelling to Africa or going to an airport, what would you say to them?
Certainly, I would have no hesitation of going to a major UK airport or a major European airport at this point in time. I think the risk of transmission is very low. That's not to say we shouldn't be alert to the signs and symptoms. Of course, we should be aware of it, but we must keep the risk in proportion.
The government has been preparing for a case of Ebola to arrive on our shore. There are currently 26 high-level treatment beds on standby. And authorities spent 8 hours last Saturday rehearsing procedures. To understand those protocols, we're going to reconstruct a possible travel-related infection scenario. I've just come back from Sierra Leone. I'm not feeling too great, so I've come to the A&E at my local hospital. What happens next?
So a patient turning up at a hospital with symptoms that could be Ebola virus, like an elevated temperature, they'll be asked what their travel history is, whether or not they might have had contact with somebody with Ebola virus. Based on those answers, what will happen is that they will carry out some testing. They'll try and eliminate other infections like malaria. A sample will be taken, and then based on that result, the patient will either be isolated as an Ebola virus positive individual or will be just monitored further.
The test results would come back within hours, and if I'd tested positive, I'd be quickly transferred to one of the high-level isolation units at one of 4 hospitals around the country. Medical staff would then need to work out if I could have possibly infected anyone else. The medical team would begin a process called contact tracing.
They would identify with whom that patient was in contact with most intensively during the period with which there was a fever.
So let's rewind our theoretical scenario. 7 days ago, I was on an airplane. I'd been exposed to the virus prior to that. But on the flight, I didn't have any symptoms. Non-symptomatic, non-contagious, so I posed no risk. When I got back to the UK, I got into a taxi to go home. Now, I didn't have any symptoms at the time, so the taxi driver's going to be absolutely fine. The doctors won't be interested in speaking to him. The Ebola virus is in my system, but I'm not contagious. They would want to work out when I started feeling ill, because that's around the time a person with the virus starts to become infectious. 2 days ago, I was back in the office. I was feeling feverish, had a headache, so I went home early. Doctors would be interested in who sits in my area and whether I spent any time with anyone that day. Ebola can't be spread by normal social contact, so sitting next to someone or shaking their hand. But what doctors would want these people to do is monitor themselves, and at the first sign of fever, to get in touch. People who had contact with me around this time would be asked to monitor their body temperature twice a day for 21 days and look out for potential symptoms of Ebola like headache or fever. Now, when I started to feel unwell, I took this train to the hospital. The doctors might want to get in touch with some of the people here, but they won't be too concerned. If I haven't been sick and I haven't been in any direct contact with anyone, everyone here should be absolutely fine.
The virus is in the blood, but it's not transmitted by contact with a person who's infected because they're not yet sick and not yet excreting or vomiting or however the virus comes out.
As the disease progresses, sufferers get sicker and become highly contagious, which is why medical teams have to wear personal protective equipment, or PPE. James Milnes trains teams in PPE protocols, and he's going to take me through the process.
Your first line of defence actually is your skin, and personal hygiene is absolutely critical, as well as covering any cuts and abrasions before you start dealing with an Ebola virus.
The key to this process is layers of protection and making sure each one is fitted properly. You're looking at all the seams at all times, I'm assuming.
With this bit it's making sure there's no rips or damages to any of the suit, and that as you get dressed, you are going to be protected with each layer.
This isn't straightforward, is it?
No, it's not. And this is why it's so important that training...
You would always have someone else helping you with this, wouldn't you? You wouldn't do this by yourself.
No, this is definitely at least a 2-person job.
Two people mirroring each other means more checks and fewer mistakes. It's called the buddy system.
OK, now we're going to give you your goggles and we're going to seal your eyes in. So put those on. If you just hold the front and the sides, I'll put these on behind you now.
Because your line of sight is very small. You can't see anything around here, anything beyond about here. That's it, really.
So you can imagine the stresses that the doctors, nurses, medical staff, people who are wearing this suit are going through.
James covers me with a simulation liquid that mimics bodily fluids and comes up under UV light. That way, he can check at the end of the disrobing procedure whether there's been any contamination. After they spray me with disinfectant, James's colleague Chris starts the disrobing procedure.
Step into the area, face that direction. There's a seat behind you.
He's doing 90% of the work, and I just follow his instructions.
Stand up and then step out. Does it?
Everything is either thoroughly decontaminated or destroyed. On this exercise, you can check to make sure the simulation fluid hasn't got through the protocols and contaminated me. But in real life, the virus is undetectable. It's an incredibly complex and time-consuming process that health workers treating Ebola patients could go through many times a day. And even the tiniest mistake could be dangerous. So James, I've been through the process. Quite a detailed thing. Whereabouts in that are the most common areas where contamination sort of gets through anyway?
Well, if you've done the drills correctly, and as we've been through today, then actually you shouldn't be getting contaminated. Where people start to struggle is where they start rushing the drills, where they're not confident in what they're doing, and where they are potentially trying to do it themselves, which is a huge opportunity for cross-contamination and potentially put themselves in significant danger. Hence why it's absolutely critical you use the buddy-buddy system, you work as a team, you train as a team, and you get yourselves out clean as a team.
It's clear that containment procedures, even in the West, are hard to uphold. And as we've seen in Spain and the US, even trained health workers can get infected. A widespread Ebola epidemic is not a reality for countries like Britain. But without controlling the outbreak in West Africa, the rest of the world can never be completely safe.
The greater the number of cases in Africa, the greater the chance that somebody will bring it on a plane to the UK. It's really important for this reason that we do everything we can to control the disease in Africa.
So in order to bring the epidemic under control, what we need to do is, of all the people who have got Ebola virus in their body today, we need to bring about 70% of those individuals out of their communities and into a safe and secure clinical facility where they can be treated well and they can also stop the transmission to their families and their communities.
A huge international effort will need to be mobilized to build the facilities necessary to incentivize local people to seek treatment and allow us to stop this epidemic spreading further. And this effort is underway. Paul Arkell is a doctor who spent 6 months treating the sick in Sierra Leone earlier this year and is now going back out there to continue the fight against the disease.
The situation is, really desperate. They really need people to go and try and tackle this problem. Some of my closest friends are in Sierra Leone at the moment, so I want to be with them and I want to try and contribute in a positive way.
Health workers going to the affected areas are putting their own lives at risk every day.
I don't have fear at the moment, perhaps closer to the time of leaving, and when I get there I may feel scared, but I don't think that's a bad thing because one needs to be always conscious that this is a very dangerous disease, and with that in your mind you're more likely to be careful.
For the moment, the treatment doctors like Paul can offer is extremely limited.
It's very humbling to work with colleagues who go into the Ebola treatment units, day after day and shift after shift with fairly limited and basic resources, able to offer pretty much only the most basic care there is, which is one human standing with another human saying, I support you, you're not alone.
Our military is essentially building an infrastructure that does not exist in order to facilitate the transport of personnel and equipment and supplies to deal with this deadly epidemic and disease.
The UK has pledged £125 million to help the fight against the disease in West Africa, as well as deploying 400 NHS staff and 750 troops. Around 3 in 10 Ebola victims survive the sickness in Africa, despite receiving only the most basic treatment. Sufferers in the West, like British nurse William Pooley, have had access to experimental treatments that have been fast-tracked. They seem to have been effective in some cases. But earlier this week, Professor Farah told me supplies are limited. People have also talked about ZMapp. Has the last available dose of ZMapp been used up?
The last dose of ZMapp available globally has now been used, and as of today, there are no other treatments through ZMapp available globally.
And it'll take a long time to reproduce those things?
It will take time to reproduce those. We're working very hard to produce them as they currently are, which is in tobacco leaves, and we're trying to put those into new systems which can be scaled up very much more quickly. But as of today, there's no more doses available.
As the search for the cure continues, an old-fashioned technique is also proving helpful.
And one of those is called plasmapheresis, which is taking blood from survivors and taking the clear part of that blood, which contains the protective antibody, and providing that antibody to patients who are sick.
We also have some experimental vaccines, and we know that one of those is currently in clinical trial, early phase 1 clinical trial. We'll get the data from that towards the end of this year, and then the hope is that if it looks to be safe, if it looks to be effective, then we'll move that into West Africa, initially probably focusing on healthcare workers.
Scientists across the world are working on treatments and experimental vaccines. Professor Tom Solomon is one of those leading Britain's fight back against the virus.
Here at the Health Protection Research Unit in Emerging Infections, we are both tracking the spread of this disease through modelling, but we're also doing laboratory research to develop new treatments. What the team have been doing is looking at how the virus causes damage within the cells, and then how we might be able to stop this happening.
It's hoped that a new international resolve will succeed in ending this deadly epidemic as quickly as possible.
This has got to be absolutely at the top of everybody's priority, because if we don't get this under control in Africa, then we are going to see continued spread. And that means that every other country in the world is potentially at risk.
Is there anything that the WHO or governments can learn for next time, whether it's Ebola or a more devastating pandemic?
I think it'll be important to look back and to see why, in the previous outbreaks of Ebola, for example, there was a robust initial response, and why in this one there wasn't. And there will be lots of looking back and lots of understanding from the lessons learned. But that's not to be done now. Now we have to focus on the outbreak and stop it.
When we see people who are suffering, we need to imagine what we would want in turn if we were that person. And for us in the West, for members of our generation, to fail this moral test right now would be a disaster.
If you've got more questions about Ebola, its threat and our preparedness, then Alok and Professor Tom Solomon are online right now to answer your queries. Just go to itv.com/tonight and link through to their Facebook chat. Until next time, though, good evening and thanks for watching.